Good afternoon, everybody. It's been such a rejuvenating session, and I must thank Dr. Sushma for getting us all on our feet. And I almost thought that my subject is too dry. I think I'll have to dance my way through it to keep the interest of the audience alive. So at the very outset, I have to thank and congratulate Dr. Sharda Jain, firstly for forming the North India Gynae Forum, and secondly for inviting me here for this talk. And as much as I wish that I could dance as gracefully as Dr. Sushma, I think I'll have to come and take some dancing lessons from you. But today we are going to deliberate on unexplained RPL. Can we decode this mystery? And each one of the stalwarts that's on the dais with me and off the dais in the audience knows how frustrating it is to have a patient with all workup normal and having a pregnancy loss. It's been a long journey between me and RPL, and my first book came out in 2003, and today we are going to bring out the 4th edition of this book next year with JP. There is such rapid advancement in our knowledge about recurrent pregnancy loss. So firstly, I would like you to like you all to think in this manner. When you see a patient across your table with a recurrent pregnancy loss, you want to, in your mind, try to figure out, is this an embryocentric loss where she is forming recurrent aneuploid embryos that are destined to miscarry? And no matter what treatment you give her, she will not carry on that pregnancy. The embryo has now two components. It carries not only the genetic DNA, but also mitochondrial DNA, and so can have epigenetic defects as well as genetic defects. And the sperm is only contributing the genetic DNA, but a high sperm DNA fragmentation will also lead to an abnormal embryo. And this is a fact we have long disregarded. As you know, in our culture, the woman is to blame if she miscarries. The husband is never at fault, even if he drinks every day, has a perfectly unhealthy lifestyle, no fingers are raised on him. But today I want to clarify that please look at the male lifestyle, which is equally important to the female lifestyle. Now, if it is an embryocentric loss, the story ends very happily most of the time because of our dear IVF specialist, and Colonel Sharma, who I respect so much, is one of them, and of course there are so many others. We all have the option of doing a PGT, selecting the normal embryo, as well as giving her donor embryos if she's not forming any normal embryos of her own. But where we always get stuck is if she's having a uterocentric miscarriage, which means if her embryo PGT result is all normal and she still continues to miscarry, this is a mystery that will take us longer to decode. So far covered that aneuploidy is accepted as the main cause for pregnancy loss, especially in women with advanced reproductive age. And I'm sure each one sees more and more of these women in their practice today than you did 10 years ago. So people start their marriages late, their careers late in obstetrics, and so you have many women that are close to 40 and come to you with pregnancy loss. These are the women that will most likely have an embryocentric loss. You need to fast track them to IVF so that they can have embryo biopsies and only put back the normal embryos after doing PGT. However, there was a very interesting study on a very small number of patients where in unexplained loss, they just didn't do anything else and they just gave them donor embryos. And they found that just by giving them donor embryos, these women had successful pregnancies. So that kind of proves, although it was only on a small number of 8 couples, but it is a food for thought that in women with high reproductive age, let us focus on the embryocentric part of it and fast track them to IVF and PGT. Now, the role of the sperm, even till now, none of the societies, whether it is ESHRE, whether it is RCOG, whether it is ACOG, recommends that we do routine sperm studies, especially sperm DNA fragmentation. But there is mounting evidence and systemic reviews which say that if the sperm has a high DNA fragmentation rate, you will treat the male partner only, improve that DNA fragmentation, and you will have a better pregnancy outcome. Makes sense, doesn't it? Coming to the endometrium, and this is what we said, the uterocentric miscarriage. The endometrium is a very beguiled organ. We can't biopsy in patients during pregnancy. We can't study it as well as we want to. But chronic endometritis, which is non-specific, which means the bacteria are very low virulence bacteria, they don't grow on culture, these women don't have any symptoms, no fever, no dysmenorrhea, yet their endometrium is hostile to implantation. And we learned this lesson through latent genital tuberculosis, and our country has endemic tuberculosis. But those women that had no signs, symptoms of tuberculosis, yet who had a positive DNA PCR, tended to have poor implantation rates and more reproductive pregnancy losses. But it's not just tuberculosis. It could be chlamydia in the West. It could be non-specific, to the point that we are now saying that we have to correct the uterine microbiome. So just as the vagina has a microbiome, the endometrium also has a similar or a slightly different microbiome. And through very elegant studies, if the microbiome is lactobacilli deficient in the endometrium, these women miscarry. So there is an emerging role of probiotics. So now we come to the very known factors, systemic factors that you all know, thyroid abnormalities. How many of us believe that thyroid should be checked in all women with RPL? Can I have a show of hands? Yeah, I shouldn't see any hand down because I think it is something you would test always. And don't just do thyroid function test. Please do anti-thyroid antibodies because it is an autoimmune type of pregnancy loss if she has anti-thyroid antibodies positive. And the only way we can treat it is with a low dose of Eltroxin. Then polycystic ovaries, how many of you believe that PCOS will have a higher pregnancy loss? Nearly all of us. We struggle first to get them pregnant, second to avoid a miscarriage, third with their GDM, and then with their PIH, prematurity, and at every step they are a challenge. And another thing which has come up only in the last year through systemic meta-analysis is the autoimmune causes of pregnancy loss. So apart from APLA syndrome, which all of us know how to treat, all of us work up our patients for APLA, there are other autoimmune disorders that will lead to a pregnancy loss. And I'll come to that in a little bit. And then there are other infections. And these are fortunately not very common in our country. But Lyme's disease is very common in New Jersey, where I was just 2 days ago. Toxoplasmosis is common in our country too. And brucellosis is common in most of the Middle East. And these infections specifically cause pregnancy loss. Now I'm going to spend a lot of time on the genetics because our biggest challenge is to diagnose the genetic and epigenetic predisposition to recurrent pregnancy loss. So it's not just the embryo. We know that we do a parental karyotype in many cases where the products of conception are abnormal. So the parents can be carrying an epigenetic predisposition to pregnancy loss. So they may have subtle genetic defects where there is subdued secretion of interleukins like interleukin 1, beta, 6, 10, 18, and that causes a pregnancy loss. Again, immune dysregulation in the mother, so she has to tolerate the foreign fetal allograft. And if there is some immune dysregulation due to some genetic defect in the mother, she will not be able to carry on that pregnancy. So in a nutshell, this is the outline of my talk, and now we will go into some points in detail. But what are the mandatory tests that you should do in all patients that come to you with 2 miscarriages? So, would you evaluate the uterine cavity? Yes. And which is the best test to evaluate the uterine cavity? Hysteroscopy? No. So hysteroscopy can miss out didelphic uterus, because you may just enter one part of the uterine cavity and think that she has a uniconvate uterus, but it may be a didelphic uterus. So hysteroscopy is not the best test, it's invasive. So sonohysterography, where you can put in some saline and do a 3D ultrasound. A simple 3D ultrasound is very good, but if you want to be one up on that, then just put in 5 to 10 ml of saline. You will get your polyps, your adhesions, your uterine malformations, everything crystal clear. I actually should apologize because this should not be karyotyping. What should it be? Microarray. So I put it there purposely to see if everyone is awake and listening. So it is so important that we check the products of conception with CGH microarray. Now when it comes to unexplained, and you have all these panel of tests normal, the mandatory test, what all do we start to test for? Do we test for AMH? Want to see poor ovarian reserve? We want to check for diabetes. Do we do HbA1c? And a new test that has come up is anti-nuclear antibodies. How many believe that it should be done? Yes, yes, a few show of hands. So there is now concrete evidence that this test will come into the foray of RPL workup. And if it is positive more than 1 in 160, it needs to be controlled. The autoimmune process needs to be controlled first. Sperm DNA fragmentation, does anyone do it? Yes, sir? Yes? Yeah. So, sperm DNA fragmentation. Procoagulable states. Now, you know, APL is one of them, but there are so many other procoagulable states which we don't know about. And we said, should we test for thrombophilias? And then we said, no, it's not worthwhile. But there is a very simple test for procoagulable states, and that is thromboelastography. Does anyone do it? So we don't have access to it. We want to do it, but we don't have access to this test. There is very little written about this test, but I can tell you that this test can prove a very cost-effective bedside test to see if your patient has a procoagulable state. She will benefit with aspirin and low molecular weight heparin. We tend to use these blindly, and they fail because if your patient does not need it, it will not work, right? So most ICUs, Gangaram, somebody said Gangaram, yes, but nearly every ICU has a thromboelastography available. So it is up to us to find out where we can do it and how we can do it. It costs a fraction of the cost of thrombophilia screening. You really don't need to know which is the factor which is deficient or not deficient. You want to know, is your patient in a procoagulant state? Will she benefit with aspirin or not? Endometrial biopsy. Does anyone do endometrial biopsy? Yeah? Which day? 20. Okay. Angela, day 1 is a bad time to do it if you want to look at chronic endometritis. Day 25 is good time to do it, but you're always worried your patient may be pregnant. You know, if she's trying for a pregnancy, how can you just tell her that now I'm going to do a biopsy for you, and then she comes with a positive pregnancy test and she'll say, oh my God, ma'am, I miscarried because you did that wrong time biopsy for me. So It is best done in the luteal phase. You have to ask your patient to not be trying for that cycle. It is to be done 15 to 25th day, as Ragini said, the time is correct. And you want to look for plasma cell concentration. Again, most of our labs are not doing syndicant staining and plasma cell concentration, but Dr. Lal's lab does it. I'm sure many others also do it. I'm not sure about where all do you send? Gangaram must be doing it too, Mala? Yeah. So this is to diagnose chronic endometritis. So if you think, my clinical cue is that if you have a patient who has had any uterine procedure before, like an HSG, like a DNC, post a miscarriage or without a miscarriage, or even any other endometrial procedure, kindly look for chronic endometritis, because our asepsis is not up to the mark. Our patients do suffer from chronic non-specific endometritis. Okay, and lastly, a very expensive test, but I have to complete the list, studying the uterine microbiome. iGenomics is the lab that does it. It's called EMMA. EMMA stands for Endometrial Microbiome Metagenomic Analysis. And it is done again day 15 to 25. If you do it in the follicular phase, you will not see anything. The endometrium has to mature first, and then only you can see whether you have presence of infections or altered levels of cytokines. And a very new test, which I only heard about when I started to prepare for this talk, is called Receptiva DX. And this is looking for a marker called BCL6, and it diagnoses endometriosis and dysregulation in the endometrium. So many of these you will not do. They're only done in desperation when your patient is miscarrying. But I just wanted to put all this into the forefront for you to know that this is where our research is going with regard to uterine factor miscarriage. So the breaking news is that after decades of research, this group of 50% unexplained is now shrinking. And why is it shrinking? Because we are doing better comprehensive genetic testing of the products of conception, and now we want to do better testing of the parents also. I'll come to that in a minute. We are doing better autoimmune screening, and I hope everyone is doing vitamin D supplementation. Any doubt regarding vitamin D? And I hope you're doing it for yourself also. So vitamin D supplementation, great immune regulator, male partner screening, and I usually do two tests. So the first is a semen culture, because the culture will tell us, I mean, you can do a semen analysis and look for abnormal forms in the semen, do a semen culture, and lastly do a sperm DNA fragmentation. But we have to look at the sperm if we feel that there is an embryocentric miscarriage. Then endometrial biopsy for screening for chronic endometritis, improving the reproductive microbiome by giving probiotics, and better imaging for anatomical defects and correcting them. So these are the things that have caused the breakthrough. If it is getting a bit too long, please indicate to me, because I can stop wherever you want me to. The gist of my talk is already across to you. But now I can give you some evidences of what I have said so far. So there are two societies that have recent guidelines on RPL, the ESHRE RPL guideline, I'm sure everyone has read it, and the ACOG guideline. They both say that CGHMA, that is microarray, is the best test for fetal tissue, and it should be done if there is a miscarriage of less than 20 weeks gestation on the second miscarriage, not the first miscarriage. Can anyone know the rationale? Why not after the first miscarriage?
Could be a chance.
Yeah, so one miscarriage is the most common reproductive failure, sporadic miscarriage, that 80% of your women can experience. So if we start to test them all, because nowadays your patients will come and say, ma'am, I have had one miscarriage and I don't want to take a chance for another one. Please work me up. But if 80% chance she's going to have a normal pregnancy, you're wasting her resources and yours by doing all this testing. But once she's had 2 miscarriages, you must do a CGH microarray and a parental karyotyping only if the products of conception are showing an abnormal karyotype. Now, why only if it shows an abnormal karyotype? Because the positive abnormal karyotype comes in only as much as 3.8% of couples. So that means 96 couples will have normal karyotype report, only 3.8% will have an abnormal report. So you are wasting their money and resources if you're testing all of them. But the minute you have a positive karyotype in the fetus and you test the couples, this number goes up way higher. And you're justified to do that. So, what is coming further down the cascade is that we are now moving towards whole exome analysis of parents. Now, it is like killing the fly with a hammer type of an analogy, because exome sequencing in RPL, everyone thought, you know how elaborate is the whole genome or the whole exome analysis. And this will pick up like so many different abnormalities which you won't be able to explain. But there are studies now to say that in this group of RPL, you are almost justified to do a whole exome sequencing because you will pick up genetic defects which have like deficient interleukin secretion or other things which are causing RPL. So this is the only paper, systemic analysis, that I wanted to present to you. There are 74 families with 279 reported pregnancy losses, and they had whole exome sequencing, and they found that they could pick up a lot of couples that had abnormal sequencing if they had RPL. So this is something as a research tool for the time being. This paper is from China, and we are not doing it that commonly at the moment, but let's go further to what happens if you do get a patient with a positive translocation. So either a Robertsonian or a reciprocal translocation in either the mother or the father. What do you advise them? You must do a genetic counseling, have the help of a genetic counselor. But remember, their pregnancy rates are equal with both of the following: natural conception and doing NIPT in the first trimester and amniocentesis in the second trimester to check that the baby is normal, or if you send them for IVF and PGT-SR. So obviously when you see an abnormal thing on your patient, you tend to tell them that you must go for IVF, you may have an abnormal embryo. But IVF and PGT-SR do not give you an equal pregnancy rate to a spontaneous conception in a fertile woman like RPL. So I myself have to share the story with you. My own secretary, she now has 2 sons who are 4 and 8 years old. She had 5 miscarriages. We worked her up, and her husband had a Robertsonian translocation. And I said, oh my God, you know, you may need IVF and all this. And she said, I'm going to give up trying, ma'am, because I don't afford IVF, I don't afford PGT. And I could see that plainly, you know, how would she afford it? So I said, okay, we'll go down the first route, and we'll check your pregnancy as soon as you get pregnant. 9 weeks, 10 weeks, we can do an IPT. And she had a couple of miscarriages in between, but she now has 2 healthy children. And she didn't go for IVF. So I wanted to break this notion that the minute you see a genetic abnormality, you have to go for pre-embryo testing, because nature is very smart. It'll only choose the best embryo most of the time. Not all of the time, but most of the time. So if you leave it to nature, it'll do the best job for you. But of course, if her age is 35, 38, 40, you can't have the same dictum. You can do it for your 28-year-old, but if she's already towards the end of her reproductive career, you can't say that and waste her time. You will have to send her for IVF and PGT. Okay, so the list of genetic defects in the embryo is ever increasing. So we used to think there are only numerical abnormalities, trisomies, aneuploidies, single gene defects. But now we have something called chromosomal polymorphism, uniparental disomy, epigenetic factors. It's like a Pandora's box, you know. You have so many abnormalities that you can look for. And in this table, you can see that CGH, what are the advantages? There's never a failure of culture like there used to be with our karyotype. There is no maternal cell contamination like there used to be with karyotype. There was a paper which said that when we sent products for karyotyping, we got a higher proportion of female chromosomal analysis because it was maternal cell contamination. The yield of diagnosis is very high. The turnaround time is 10 to 12 days, so it is the recommended test, just slightly more expensive than karyotype, but has huge advantages. Any questions on CGH? Anybody feels this is beyond reach or should not be done? No. Then we come to single gene defects. We can pick it up with CGH, but I need to take you back to the last column here, which is called NGS. And NGS is the genetic test of the future. It will diagnose single gene defects. Its yield is very, very high. Its turnaround time is a little longer, and its cost is again double that of CGH. But it gives you so much more detail in the analysis than karyotype or CGH. And single nucleotide polymorphism, microRNA, epigenetics. And another interesting thing is uniparental disomy. Which condition do we know which causes uniparental disomy? H-mole. Have you ever seen a patient who's had H-mole and RPL? Yes? Absolutely. How many? Yeah. Interesting. There is a strong association. So I had a patient who had alternate. You know, she would have a molar pregnancy, and then she would have a normal pregnancy but miscarry, and it seemed like a mystery. She had something like 6-7 miscarriages. So uniparental disomy is coming up as a big factor in RPL2. We don't know how to prevent it. You can only prevent it by IVF, ICSI, and make sure, I don't know even whether ICSI would prevent it. No, not really. Yeah, we don't know what to do about it really. And chromosomal polymorphism. So I will leave this topic here and take you through this concept called ERICA, Intelligent Classification Algorithm, which means that if you're doing IVF and then PGT, then you use this ERICA to rank which is the best embryo to transfer first, so that the time to pregnancy is reduced. Our dictum with IVF always is put in the best first, so that she gets the best chance in the first IVF embryo transfer. Okay, so this was the difficult chapter of genetics, and now I will come to the autoimmune disorder. So we think that if she has vitiligo, if she has alopecia, this is not related to her reproduction, it is just by the way present. But there is a huge correlation with any autoimmune disorder, and one of my residents had uveitis, chronic uveitis, and it was autoimmune uveitis. And again, then she used to have a poor reproductive outcome. So you can link any autoimmune disease, if it is in the active or the flare form, it will alter the endometrial reaction to the embryo implantation. So here I don't recommend you do very expensive tests. All you need to do is take a good history. And very often you will see alopecia, vitiligo, anything else, and you will know that instead of having this kind of a response, the endometrium is behaving abnormal. So control the autoimmunity first, and this is the evidence that there is a systemic analysis which says that if the ANA titer was high, the miscarriage rate was 28%, and if it was low, the miscarriage rate was low. And here is your rationale for half the world turning vegan. Why do one, we have never known this world, but the West is all turning vegan because these foods are antigenic. Eggs, meat, soya, peanut, dairy, gluten. And these antigenic foods will trigger an autoimmune reaction. So, if you have a patient, it's better to tell her to become a vegan. So I'm nearly to the end of my talk, and sperm DNA fragmentation, I've already emphasized that it is a test which is coming up in this armamentarium, and this is the SWOT analysis for sperm DNA fragmentation, that it is a test which is not standardized and it's expensive. That is why it is not used that often. But we are getting newer tests now like toluidine staining, which will make it simpler and we can use it more often. And you must give the husband antioxidants for 3 months. So this is the thromboelastography, and this is an old test, bedside test, and we have neglected it so far. And chronic endometritis, you need to do a biopsy. Treatment is with specific antibiotics if you have a bacteria growing, or with probiotics for 3 months. Endometrial microbiome is also available for study. So coming to management options, first and foremost, lifestyle modification. So please remove alcohol, drugs, tobacco, and any other environmental pollutions. Optimize her BMI. Dydrogesterone is recommended for immune modulation in unexplained. The PROMISE and the PRISM trial have shown that natural micronized progesterone don't work. And how fortunate I am today to have Dr. Ashok Kumar here, who himself has done a primary study on this subject, which is internationally acclaimed, and it has proven that dydrogesterone reduces miscarriage. So, and the other is tender loving care. Every talk you hear that, but how do we give tender loving care? I mean, not just sweet talking, I think reassurance scans. So they recommend that every week the patient comes to you, do a quick scan, check for the fetal heartbeat. If it's present, she goes home reassured she has won the battle. What are ineffective therapies? Just giving her aspirin, low molecular weight heparin because it works in APLA, it may work in unexplained, it doesn't work. Giving her IVIG, it doesn't work. Giving her GCSF, again a very elegant meta-analysis, it doesn't work. Doing IVF in the right indication will work. And Murugappan's study was the first one which said that the time to pregnancy got reduced if we did IVF and PGS. And oocyte donation is an option where she forms no normal embryos at all. And if her endometrium is chronically damaged, then unfortunately we come to the controversial subject of surrogacy, which I will not want to touch. But what is new? Stem cells, PRP, they're making their way into treatment of chronic endometritis. And sitagliptin, which is an anti-diabetic drug, is shown to increase stem cells. So with all this big group of 50% unexplained is now shrinking, and we think that it is left to about 10 to 15%. Thank you very much, and a very happy new year to all of you.